So without further ado, I now turn to formally introduce Professor Sir Michael Marmot, who will present the open lecture on social justice and health equity. It is impossible in the time available to summarise Michael's achievements, but there is one slide, if you could project it, please, Kate, which summarises some of his achievements. Although born in the UK, Michael's story began in Sydney when he was raised and graduated from medical school at the University of Sydney in January 1969. One line in his biographical entry in the medical school senior yearbook reads, and I quote, "His ever-questioning nature prompted an exasperated surgeon to remark, 'Stop thinking and start memorising.' Fortunately, Michael did not take that advice. 2 years later, there was an article in one of Sydney's newspapers that read, and I quote, 'A young Sydney doctor has been awarded a grant to study social and preventive medicine under American workers who have found a connection between coronary artery disease and changes in social status.' In that article, Michael is quoted as saying, 'They found that people who were socially mobile, who change their jobs, their surroundings, their style of living, are more prone to coronary artery disease than people who remain in the one social situation. This is probably connected with stress factors.' Michael never returned to Australia to work after leaving for the US and then the UK, although of course he has visited many times and given many lectures. He has been based at the University College London since 1985. So in the 50 years after leaving our shores, Michael has forged a world leadership position in social justice and health equity. Along the way, he was principal investigator on the Whitehall studies of British civil servants, in which he showed that the lower the position a person in the hierarchy, the higher their risk of a wide range of diseases. Along the way, Michael has had major global impact, as you can see from the appointments noted on this slide. There are many others as well. He was knighted by Queen Elizabeth in 2000 for services to epidemiology and the understanding of health inequalities. It is fitting that his lecture tonight will have an international audience, and also later as viewers of our YouTube channel listen in. Viewers tonight, note that Michael is available in real time in London for the Q&A following his presentations, and I encourage you to write your questions in the Q&A feature on your screen. Professor Sir Michael Marmot, welcome to the 1323rd General Meeting of the Royal Society of New South Wales.
It's a great pleasure to be able to talk to you. As you may know, I lived in Sydney from the age of 4 till 25. I went to Wallara Sydney Boys High, studied medicine at the University of Sydney, and then left, intending to come back, but somehow it never happened. I went to Berkeley, California, and then to London, where I've been ever since. And the work that I've been doing initially was focused pretty well full-time on research on health inequalities, social determinants of health. But then I chaired the World Health Organization Commission on Social Determinants of Health, which was a way of trying to package what we know about the influences on health and health equity into a form that would influence policy and practice. In the wake of that, what I'll talk about, I was invited by the British government to answer the question, how could we apply the findings of your global commission to one country, England? And in 2010, I produced the Marmot Review. I was commissioned by a Labour government The government was voted out soon after. I don't think there's a causal connection. And 10 years on, in 2020, we published the Marmot Review 10 years on to look at what had happened to health and health inequalities in England in the previous 10 years. And we've been looking at it ever since. So that's really the thrust of what I'll talk about now. I called this social justice and health equity. We use data and evidence, but it's all in this pursuit of creating greater health equity, narrower health inequalities. And it's a matter of social justice. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. We are, particularly at the time of the pandemic, particularly concerned with the healthcare system. My concern is with the social determinants of health, the conditions that make people sick in the first place. I mentioned that I had done these two reviews, the Marmot Review in 2010 and Health Equity in England, the Marmot Review 10 years on. We had initially 6 domains of recommendations to reduce health inequalities. Give every child the best start in life, education and lifelong learning, employment and working conditions. Number 4, really radical for a rich country. Everyone should have at least the minimum income necessary for a healthy life. Number 5, healthy and sustainable places in which to live and work, including, of course, housing. And number 6, taking a social determinants approach to prevention. We've now added to, particularly number 7, in light of COVID, tackle racism, discrimination, and their outcomes. And number 8 was really there all along, pursue environmental sustainability, tackle the climate crisis, and health equity together. This is from my 2020 10 years on review, updated, and it was asking what happened in the previous 10 years. So if you look at England, life expectancy had been improving about 1 year every 4 years for women and for men. And in 2010, when we did the review, there was a break in the curve. And the rate of improvement in life expectancy slowed dramatically and then fell in the first year of COVID. What happened in 2010? There was a new government elected, a conservative-led coalition government. They were a bit sensitive to the idea that I might be alleging that anything they did might have had something to do with it. Well, indeed, I did allege that. We looked at the evidence, and that's what I'm going to go through. And by and large, if you take my original six domains of recommendations, what the government did pretty well in all 6 was move in the wrong direction. And health inequalities, not just did life expectancy stop improving, health inequalities got bigger. If we look at London and the northeast of England by level of deprivation, both for London and the northeast, it's a social gradient. It's not just that the most deprived have shorter life expectancy, but the greater the deprivation, the shorter the life expectancy. Now, if we compare London and the northeast, for those in the least deprived decile, the differences between London and the northeast are quite small. But then, the greater the deprivation, the greater the disadvantage of living in the northeast. Putting it a different way, the gradient linked to social deprivation is steeper in the northeast. Now look at what happened over time. The dotted line is 2010-12, and the solid line 2016-18. And all along the deprivation gradient, life expectancy improved a bit in London. But in the Northeast, it fell in the poorest 10%. It didn't improve for the bottom 6 deciles. So the regional difference got bigger. The inequality gap got bigger, and life expectancy for the poorest people went down. This is what happened in the 10 years. Just, you're maybe asking, where does Australia fit in all this? Japan, Korea, Norway, Australia, Switzerland, right up there. Australia looks pretty good. If we look at Australia as a whole, if, as you know well, we look at Indigenous, non-Indigenous women, Indigenous women, and non-Indigenous men, Indigenous men. Now, it does appear that the gap has got smaller. We used to talk about a 17-year gap. Now it looks like fewer than 10 years, if you believe the numbers. But the gap is still enormous between non-Indigenous and Indigenous women and men. So yeah, Australia looks pretty good if you ignore the huge gap between Indigenous and non-Indigenous. A lot of work to be done. Let me just say a word about aging. It's possible to think that, well, yeah, this inequality stuff affects children, younger people, maybe working age, but aren't we all equal by the time we get to be very old? No, we're not. Look at dementia and deprivation. The less the deprivation, with a bump up here, but in general, the less the deprivation, the smaller the risk of dementia. Ethnicity in Britain, well, in East London, Black British and to a lesser extent South Asians have higher dementia risk. And then various risk factors for dementia, depression, head injury, diabetes particularly. And still sticking with the older person's theme, the greater the deprivation, the greater the risk of fractures. General fragility goes up with deprivation. Fracture of the radius and ulna go up with deprivation. Fractures of the hip, greater deprivation, higher likelihood of hip fracture and spinal fracture. These inequalities in health persist into the oldest age group. So coming back more generally, I said that I think the worsening health picture, just to remind you, in England, we had a near flattening of improvement in life expectancy, an increase in inequalities linked to region and deprivation, and life expectancy for the poorest people getting worse. And I think it is related to a decade of austerity, which is continuing. The government that was elected in 2010 made austerity, reduction of public spending, their key aim. And by golly, they did it. In 2009-10, public sector expenditure was 42% of GDP. It went down year on year. By 2019, it had gone down to the 42%, had become 35%. And then in the first year of the pandemic, a dramatic increase. The Chancellor at the time, the Minister of Finance, said, whatever it takes, Here's a trick question. Can you remember who the British Chancellor was in 2020? Well, it is a trick question because we've had 7 chancellors, 7 ministers of finance since the Brexit referendum in 2016. Wow. Well, there's a clue. The then Chancellor is now the Prime Minister, and that's a bit easier. We've only had 5 Prime Ministers since the Brexit referendum of 2016. Utter chaos. But I digress. Coming back, the Chancellor, Rishi Sunak, said, whatever it takes, faced with a grim economic picture and health picture, he said, whatever it takes. And I thought back to 2009-10. Faced with a grim economic picture, the Chancellor did not say whatever it takes. He said, we must cut public expenditure or we'll be like Greece. Actually, Greece's economy is looking quite good. He presented it as a moral necessity, an economic necessity. But faced with a bigger problem, the Chancellor said, whatever it takes. It makes me think this was not a moral necessity in 2009-10. It was a political choice. And the evidence suggests that political choice did great damage with the dismal health picture that I've described. Children have consistently had the highest poverty rates. Look what happened to pensioner poverty. And with the slowdown in public spending, they tried to make clear that pensioner poverty didn't go up so much and it's much lower. I'm not sufficiently cynical to pass the observation that older people are more likely to vote. And perhaps if their incomes don't go down, they're more likely to vote for the Conservative government. But I'm not cynical enough to think that. But look at children who don't vote. Child poverty, defined as less than 60% median income, was 27% after housing costs in 2010. And over the decade, that 27% went up to 30%. It went down in the first year of the pandemic with the Chancellor's extra spending, but it's going up again. And that 30% will probably become something like 34%. Child poverty went up. And deep poverty. So if you look at the proportion of people in poverty, in deep poverty, that's less than 50% median income, and very deep poverty, less than 40% median income. You can see the share of people in poverty who are in deep or very deep poverty has been rising with real consequences. Child poverty rates, less than 60% median income from UNICEF report card 18. Colombia, United States, Italy, UK. Australia looks certainly a good deal better than the UK, but not as good as Norway and Denmark. But among 38 countries, the UK had the biggest increase in child poverty. This was the years of austerity. A consequence of government policy was to increase child poverty. And if children are in poverty, their parents are in poverty. It means their parents don't have enough to live on. And the architect of these policies, George Osborne, who was the Chancellor of Exchequer, the Minister of Finance, in 2010, he said a country has to live within its means. The economic policies we pursued after 2010 meant we had the strongest growth in the G7. More jobs were created, a lot to be proud of. Britain in 2016 was buzzing. People were looking at the UK and saying, that's the example we want to follow. And I thought, where was I in 2016? I don't recognize that's the example we want to follow. What did it look like? This is the change in real wages since 2009. Here's the UK, and here are the comparison countries. They were looking at the UK in 2016 and saying, that's the example we want to follow. We wish our people were poorer, that low incomes had declined. To put it in perspective, this is what happened under the Conservative government, under New Labour, and under the Conservatives. And these are the peer countries. What garbage! It's bad enough to pursue policies that damage the country and then lie about it and say we did wonders and everybody was envious. Good heavens. Total government spending compared with comparison countries as a percent of GDP went up under Labour and went down dramatically. There's the average for the comparison countries, went down dramatically under the Conservatives. Government spending on healthcare, it was rising slowly under the Conservatives, steeply under the New Labour, and down under the Conservative-led coalition and then Conservative government. I said this is not mainly about healthcare, but healthcare is important. If we take the number of people waiting for treatment in January 2009, near the end of the Labour period, as 100, then the number of people waiting for treatment at the end of the Tory Thatcher Major period was 230. And then it went up inexorably, steeply. By 2019, it was back up at 190. It then went up steeply after that. But the government ministers are blaming the number of people waiting for treatment on the pandemic, on the war in Ukraine, on the doctor's strike, on goodness knows what. But the fact is, it had nearly doubled before the pandemic, before the war in Ukraine, before the doctor's strike. It may well be related to starving the NHS of funds, which is what happened, and waiting in accident and emergency. The share seen within 4 hours plummeted. I did something that I wanted to do for a long time, which was focus not on the poorest and say, the poor have very poor health, but focus on the richest. And I don't mean worrying about people getting sick when they go on holiday in the Bahamas. I mean, the least deprived. Tell us what's possible in terms of mortality. And health follows a social gradient. And so we've calculated excess deaths, the number of extra deaths attributable to having a level of deprivation below the very top. And you can see how, of course, it rises steeply with deprivation. And over the 10 years, from 2009-10 to 2020, there were 1 million extra deaths, excess deaths in England linked to deprivation. Now, given that there was a social gradient prior to 2010, we looked at how much steeper it had got. And of that 1 million excess deaths, 148,000 could be attributed to austerity. The fact is, the gradient had got steeper. And then in the first year of the pandemic, there were a further 28,000. Before I boasted, if I'd been the Minister of Finance, before I boasted that we were the envy of the rich world, I want to make sure that my policies weren't responsible for 148,000 extra deaths. And look at income in the UK compared with other countries. So this is income adjusting for purchasing power parities. Switzerland and the United States, if we look at the 90th percentile, So 10% from the top, Norway, the UK, and Slovenia. Our richest 10% are as rich as Norway, but poorer than the US and Switzerland. Good deal better than Slovenia. The median, the 50th centile, we're now quite a bit poorer than Norway, who are up there nearly with Switzerland and the US. And our poorest 10%, we're a long way below Norway and Switzerland. In fact, Slovenia, the poorest 10% in Slovenia, are richer than the poorest 10% in the UK. You look at these figures and say, we're a poor country with a few rich people. People like me have been saying, oh, we've got the 6th biggest GDP in the world. Well, maybe, but it's not very well distributed. We've got some very rich people, and everybody else is not very rich. Look at this. If you look at the national average GDP per person, gross domestic product per person, and then take out the richest region, London, the GDP per person goes down by 14% if you take out the richest region. Now, look at Germany, higher GDP. Take out the richest region, Munich, Bavaria, doesn't change. The wealth is spread around the country. Netherlands, take out the richest region, Amsterdam, goes down by 4%. The US, take out the richest region, Seattle, well, there's a lot of wealth around, goes down by about 2%. In Britain, if you take out the richest region, London, our average GDP per person, adjusting for purchasing power, is the same as Mississippi, the poorest US state. The UK is Mississippi with one rich region, London. No wonder we're in trouble. And coming back to Australia, a growing share of the wealth in Australia is held by the older generation, the 65 plus. And that share has been growing. For younger people, it's going down. So the first big challenge in the UK was the decade plus of austerity. Then, of course, came the pandemic. And we said the pandemic would expose the underlying inequalities in society and amplify them. And so it proved. Levels of deprivation, all-cause mortality. You can see the social gradient. And here's COVID mortality. It follows the same social gradient. Slightly steeper for COVID because of excess deaths in the most deprived lowest 3 deciles because of employment in frontline occupations, overcrowded housing. But in general, what it shows is that to control COVID, yes, we need social distancing. Yes, we need vaccination, but we also need to address the inequalities. And when I said it amplified the inequalities, is life expectancy 2018 to 20 compared with the previous 3 years by level of deprivation. And for men and for women, the greater the deprivation, the greater the fall in life expectancy for the bottom 4 deciles. For men, it didn't improve at all in that 3 years. For women, it improved in the top 6. But for both, the greater the deprivation in the bottom 4 deciles, the greater the fall in life expectancy. And if we look at healthy life expectancy, this is for women, not only do women and men in the poorest decile have shorter life expectancy, they spend more of their lives in ill health. So women in the poorest 10% can expect to live a third of their lives in ill health. And if we look at destitution, very deep poverty, all UK households, single working age, particularly liable to destitution, a couple with no children, less likely to be destitute. Our benefit system has got rolled into something called universal credit. So if you require benefits, you get universal credit. The Joseph Rowntree Foundation and the Trussell Trust calculated the cost of what they called meeting essentials. This is the cost of meeting essentials for a single person. And this is the level of universal credit, the cost of meeting essentials for a couple. And this is the level of universal credit. If you're on benefits, universal credit pays about 70% of the cost of meeting essentials. If you're on benefits, we guarantee you will get sick because we don't give you enough to have a healthy life. And then there's various aspects. We've produced a series of reports on fuel poverty. Growing up in a cold home damages children's lungs. It damages their intellectual development. They have higher risk of mental illness. And of course, it increases the excess winter mortality in adults. And we said epidemic levels of fuel poverty will cause a significant humanitarian crisis. People couldn't afford to heat their homes. 3 causes of fuel poverty: poverty, the price of fuel, and the thermal property of housing. And our energy prices are 20% higher than the European average. Why should that be? Well, my suspicion is it relates to the way we privatize the energy market, but there you are. And the energy efficiency of our housing is the worst in Europe. And then I've been talking about household poverty. The excess winter deaths in England and Wales varies with how bad the winter is. But look at this, huge, not just because of a cold winter, but because people couldn't turn on the heating sufficiently. And the cost. This is the percent of the household budget spent on energy. If you're in the top 10% of income in France, you spend 6% of your household budget on energy. And if you're in the top 10% of income in the UK, you spend 6% of the household budget on energy. If you're in the bottom 10% in France, you spend 10%. If you're in the bottom 10% in the UK, you spend nearly 18%. That gap between the poorest 10% and the richest in the percent spent on energy, that gap is bigger in the UK than in any other European country. To repeat what I showed you earlier, the UK is not a good place to be poor. And lack of key essentials in the previous month, reported by the 3 main subgroups of destitute households: migrants, people with complex needs, and others in the UK. Food, heating, clothes, toiletry, lighting, shelter. These 6 basics, look at the high proportion that are reporting lack of these 6 basics. And there's been complaints that the tax level in the UK is the highest for 70 years. Yeah, but let's get a perspective on it. This is the tax burden in the UK. ONS is the Government Statistical Office, the OECD. And the tax burden in the UK, depending which figures you look at, is about 34% of GDP. In the EU 14, it's 40%. The G7 average is 37%, apart from those in the EU 14 and the UK. We are a low-tax country. We've got terrible public services because we don't spend any money on them, because we're a low-tax country. The cliche is we want US levels of taxation and European levels of public services. Guess what? It's not happening. That's all very grim. But I'm not grim. I have good news. In the UK, more than 40 places have declared themselves Marmot places. Coventry was the first. It said, we're going to be a Marmot city. They took my 6 domains of recommendations in 2010 and said that will be the basis for our city planning. Greater Manchester took it on. The pandemic struck while we were working with them, and we called our report Build Back Fairer in Greater Manchester, Health Equity and Dignified Lives. Cheshire and Merseyside, Liverpool is the largest city in Cheshire and Merseyside, altogether fairer. Lancashire and Cumbria, Luton, a Marmot town, the London Borough of Waltham Forest, Gwent in Wales, Southwest, Leeds. I was in Scotland yesterday. We're talking with Scotland about taking this on in various parts of Scotland. It's really exciting. And then I was approached by Legal & General, a large insurance and financial services corporation. They have 1.2 trillion pounds under investment. And they said, what can business do? And they sponsored us to produce a report, not just for Legal & General, but what business could do. We called it The Business of Health Equity, the Marmot Review for Industry. And we said 3 areas: good quality work, pay, conditions. Second, goods and services. If you're the tobacco industry, we can't work with you. What you do is bad for health. If you're the food industry, what you do could be bad for health, or it could be good for health. We'd like to work with you to make it good for health. So goods and services, clients and customers, and the wider impact on the community, the environment, procurement, employment, and the like. We're working with a healthcare provider, the East London Foundation Trust, and a public health doctor said, we can do that in the East London Foundation Trust. A training and employment provider, think about our service users and the wider Luton community. The leader of the opposition Labour Party, Keir Starmer, last year unveiled a health mission. And in an appendix, which very few people read, but I read it, it said the next Labour government will amplify the approach of Marmot cities like Greater Manchester and Coventry by making England a Marmot country, tackling the social inequalities that influence health. Good heavens, you may see an exit of Brits to Australia fleeing a Marmot country, but still, it'd be good to hold them to it. So let me finish. For most of this talk, I gave you a lot of reasons for despair, but I hope there's a glimmer and of something different. Raymond Williams said to be truly radical is to make hope possible rather than despair convincing. To bring you up to date, we published a report yesterday on the 1st of May. We're recording this on the 2nd. That shows the picture at least as bad as I've just shown you. And even worse, one graph that I have, next time I give you a talk, maybe I'll show it to you. If you look at life expectancy for local areas in 2010-12, and then look at the reduction of spending power by local government in the subsequent years, the shorter the life expectancy in 2010-12, the steeper the reduction in local spending in the subsequent years. Good heavens, in what moral universe could you justify looking at need and then taking money away from those that need it most? Was this a deliberate policy to increase health inequalities? And if it wasn't deliberate, was it absent-mindedness? Does that make it any better that government policy was to look at life expectancy, and the shorter the life expectancy, the steeper the reduction in local spending power? It gets worse. Indeed, it does. And I began this journey saying that I'm not party political. And indeed, I did not want to be party political. I wanted any government to take on board my recommendations. The problem is the government that we've had in Britain for the last 14 years has made the situation very much worse. I'd like the government to change, and that doesn't necessarily mean a new government. It means a government that behaves differently. In practice, it means a new government, because this government has shown no interest. And my own view is, what could be more important than the health of the population? What other goals were more important than that one? And I think they failed miserably.
Thank you, Michael. Distressing, depressing, and slightly uplifting presentation. The first question I'll take myself, what's happened since May, particularly as the election is, if not tomorrow, very soon?
Well, the election is tomorrow, and what's happened in the election campaign has been rather dispiriting. The subtext of what I presented to you, and let's make it explicit rather than implicit, is that evidence is key. Many of us come from a scientific background, and what we rely on is evidence. We argue like anything about the interpretation of the evidence, but the evidence is absolutely key. When the Prime Minister was asked the question, and he said, life in Britain is better since 2010. Well, since 2010, up to 2022, in a 13-year period, life expectancy has not improved, because it went down in the first 2 years of the pandemic. I don't know of another 13-year period in peacetime in Britain since 1900 when life expectancy has not improved. And health inequalities got bigger, and health for the poorest people got worse. How on earth can you say with a straight face that things have got better in Britain since 2010? They haven't. They've got demonstrably worse. And I look at health as the most important, but I could look at the criminal justice system. I could look at spending on education. I could look at the pollution of our rivers and our waterways. It's all got worse. So with a straight face to say it's got better, well, what we do is try and look at the evidence. I guess he's not going to campaign for re-election and say, we rather messed this up, but give us a chance, we'll do better in the future. It's not compelling.
Thank you. I encourage viewers to put their questions in through the Q&A. We do have quite a few already. This one is from Christy Slade, who says, Michael, you're on the record as saying a health system for the poor is a poor health system. You are familiar with the UK system and also the Australian healthcare system, I assume. How would you compare the two in light of that comment and in general from the point of view of the evidence that you've been presenting?
Well, when I was chairing the WHO Commission on Social Determinants of Health, I was asked going into the commission before we'd set it up, but before we'd done our work, whether I had a view about public or private provision of healthcare. And I said, quite honestly, no, I don't, but I'll look at the evidence. When the commission finished its work, I did have a view that countries with higher public provision of healthcare in general have better health. Before the NHS was systematically undermined by government policy, the Commonwealth Fund ranks the healthcare systems of 11 countries, and the UK always came out number one. And the thing that was most marked was equity of access. If you look at access for people below and above the median income, the UK particularly came out number one on equity of access. And that, in fact, was important in my coining the term proportionate universalism. A universal healthcare system, like the NHS, is a statement of value as well as a pragmatic way to treat people's health. But we don't spend on everybody equally. Our effort is proportionate to need. Of course, if you've got diabetes with peripheral vascular disease and cardiovascular disease and renal disease and ocular problems, we spend more on you, rightly so, than if I'd like to die bungee jumping at 99 when the rope snapped. And I wouldn't say, damn, I paid my taxes all these years and never used the healthcare system. It's proportionate universalism. Well, I want to use that idea more generally when need is defined socially as well as clinically. So to answer Kirsty's question, it's a statement of values to have the same system for everybody. But to be pragmatic, we need effort proportionate to need.
Thanks, Michael. There's a question, I think it's from Chris Bertrand, certainly Chris D. Brilliant presentation. Regarding the reasons for hope, I note that the Labor Party is committed to increase NHS funding by less than 2%, which of course would go nowhere to address the years of austerity. Can we really expect things to get better under the new government, given that as the policy of the possible incoming government?
Well, I'm not a political consultant. I don't know what parties have to do to win elections. The Labour Party has taken the view to win the election, they have to be immune to Tory attacks. and the right-wing press attacks about, oh, all Labour governments can do is tax and spend. So they've been rigorous in not opening. They've been attacked for doing that, even though they've been rigorous in saying they won't do that. If they were asking me what they should do, I would say spend some more money. That might not help them win the election. So I'm a bit concerned that they box themselves in by saying that they'll stick to these rigorous spending restrictions. All that said, in the work that we've been doing with these Marmot communities around the country, in a recent report that I mentioned at the end of my lecture, we documented that the central government support to local government over the decade from 2010 went down by 59%. Wow, 59%. Now, after 2015, local government was allowed to raise more money. So the spending power of local government went down only by 34%. But the more deprived the area and the shorter the life expectancy, the greater the reduction. And despite all that, these local areas have said to us, we want to work with you. We want to work on your 6, now 8 domains of recommendations to make a difference. So although I would like a new Labour government, if that's what we have on Friday morning, to spend more money, there's a lot they can do without spending a great deal more money. And that's what we've been doing with areas all around the country.
Right. From Peter's iPad, a question. So, Michael, is this gap between relatively wealthy and poor going to widen as vectors such as education, technical ability, and location become more influential? I'm just trying to understand the rest of the question.
I might help with that.
Yeah,
so the question is asking, so Michael, is this gap between relatively wealthy and poor going to widen as vectors such as education, technical ability and location become more influential before the advent of artificial general intelligence as a new governor of human welfare?
Well, the big increase in income inequality in Britain was in the early years of Margaret Thatcher's premiership. And it went up quite starkly. Wealth inequalities have continued to increase, but income inequalities increased under Margaret Thatcher. They did not increase further under John Major, and they didn't change much. They didn't go down under New Labour or the governments. We've had 5 prime ministers since 2010, 7 ministers of finance. I mean, utter chaos. But the inequalities in income didn't change much. The problem was that when you've got inequalities in income, which were quite large because they went up under Thatcher, but when the economy stops growing, I think largely because the government failed to address the problems, low productivity, and then you take the decision to decrease spending on welfare, on public services and the like, then you've got a real problem. To come to the second part of your question, if I understood it, will inequalities in intelligence, cognitive ability, will they play a more important part? I mean, the evidence is that you can make a real difference to that. If you look across Europe, the inequalities in outcome in Denmark, in Finland, Norway, Sweden, linked to parents' income are much, much smaller, whether we're looking at income of the next generation, at educational performance of the next generation. Who your parents are matters much less in Denmark, Norway, Finland, Sweden than it does in the UK and the US. Australia is somewhere in between. If you're in Brazil, who your parents are matters enormously. The inequalities are much bigger. So the fact is that social policy can make a difference to the degree to which the circumstances in which you're born shape your life chances. It's not, one of my colleagues at UCL was on the BBC. He was being asked to comment on some paper about genes and IQ from China, and he was quite disarming. I thought he was terrific. He said, I haven't read the paper. You only gave me 10 minutes notice, so I haven't read the paper. But you're trying to say this twin study settles it for genes. It doesn't. We know genetic inheritance is very important, but we also know that the meterage of books in the house is important for children's development. So, and this paper doesn't change that conclusion. There's environment's important, inheritance is important. And in a way, the balance doesn't really matter. Let's focus on what we can do to improve things.
There's a question from Simeon Simoff, which I think is asking whether you think that deeper dives into the demographic data to give even more evidence will advance the arguments for governments to do something. In other words, are you able to gather enough evidence, and if not, what are the impediments to that?
Well, we're blessed in Britain. Australia's pretty good on this, but we're blessed in Britain with high quality evidence, both government statistics and a strong research base. So my recommendations are based on compiling the best evidence we can, consulting widely in the experts in each of those areas. And I mean, to take one example, which is highly relevant and very important, early child development. The new Labour government launched Sure Start in 1998, a year or maybe 2 years after they came into office. This was largely based on the American Head Start program, but also a lot of evidence about the importance of inputs into early childhood. So to improve cognitive development, social, emotional, psychological development. And the Sure Start was set up to help families and children, particularly more deprived families and children. They did, to their credit, they set up an evaluation of it. So when it was set up, there was an evaluation. But being politicians, the pressure, they were so pleased with what they'd done that they rolled it out before the evaluation was finished. So now we had a bit of a mess because the control areas were getting Sure Start and the quality of what was being implemented varied enormously if you roll it out on a mass scale. So the evaluation was somewhat ambiguous. people like me who thought that early childhood was very important found scraps of evidence from the evaluation that supported the observational evidence that we had. And people who were suspicious of any government program said, you see, it doesn't work. Now, I said it was implemented around 1998, 99. This year, a few months ago, the Institute for Fiscal Studies published data that children involved in Sure Start had 3 grades better in their GCSE performance. That's the national exam young people do at age 15 or 16. So it's the difference between 3 Ds and 3 Cs, or 3 Cs and 3 Bs, 3 grades better. So what's my message? Well, yeah, we do need the evidence, but it can take a long time, and to assemble that evidence, and it's certainly beyond the time frame of most politicians. And if you've got a 3-year election cycle, within a few weeks of being elected and being in office, you're thinking, what have you got to do to be re-elected? We've got a 5-year cycle, which gives you a bit longer, but even so, it's going to take a while. So the evidence is key, but we shouldn't overplay it in these short-term political decisions.
Are the Marmot communities short-term, based on council election cycles, or are they likely to be a longer lasting program?
I hope they'll be longer lasting. Coventry, which was the new chief executive of Coventry City Council, like any other person of that kind of leadership, doesn't simply want to do what her predecessor did. She wants to stamp her own mark. But we had a good conversation. She said, let's work on what Marmot 2.0 might look like. So Coventry's been doing it for 10 years. And now the new leadership want to think about the next phase, not simply repeating. With Legal in General, the big corporation that we've been working with, the chief executive retired, and he was very much the inspiration. It was his idea to approach us, to work with us. But I met the new chief executive. He doesn't simply want to continue what his predecessor did, but he committed himself to continuing with us, but to think about what the next phase would look like. So I think we shouldn't settle into complacency and say, we've got a way of working, let's just continue it. We should be looking at it all the time, but not making rapid short-term changes for the sake of it.
Thank you. Final question to bring it back to the Australian context is from Chrissy Slade. She says that you did mention the glaring health divide in Australia affecting Indigenous communities and the extreme social determinants of health for those communities. The solution has eluded successive governments, successive not-for-profits. Do you have any suggestions?
Yes and no. I remember after one trip to Australia, I arrived and I was asked this question. I said, I just arrived, I'm jet lagged. Give me another 24 hours and I'll give you the answer. I'm being glib. I would say what we've learned, and I can describe it as something I learned from the People's Health Assembly in Thailand. They talk about the triangle that moves the mountain. And the triangle that moves the mountain the three corners are the academy, knowledge, government, and the people. And we need all three working together. It's very clear to me that without involving the people, you get it wrong. And in various trips to Australia over the years, I've tried to engage with representatives of the Indigenous community, and I've seen inspiring examples of community organization, of people being active. Now, they may only be pockets, but they're inspiring examples. You can't do it without government support. And I'd like to think that knowledge of what works to make a difference is vital. So I'm talking about a process, not simply a recipe, do A, B, C, and D, but the importance of lived experience, of community organizations is vital, government support, and using the best knowledge is certainly a way forward. I mean, the graph that I showed you, if you believe the numbers, does suggest some narrowing of the gap in life expectancy, which is encouraging. We know there have been big improvements in university education and qualifications for the Indigenous community. The number of doctors, nurses, teachers, and the like has improved. So it's far from something that's hopeless to say, oh, look, it's long-standing, there's nothing we can do. That's not what it looks like. It looks like progress is possible, a long way to go, but I would try to use the triangle that moves the mountain.
That is a wonderful line to end tonight's lecture, and thank you very much, Michael, for joining us. It's
my pleasure.
Early in the UK. I think it's not the middle of the night, so at least that's one advantage. And we're all runged up for winter, but you're looking quite summery. So I hope that you have found it interesting to prepare a lecture for the Royal Society of New South Wales. It may be your first, but hopefully not your last. We are not as old as the societies in the UK and Ireland, but we are up to our, I think, whatever the number was that I said tonight, 1,300 and something ordinary general meeting and open lectures. So we are very much aligned with your triangle of the academy, government, and the community working together to advance any of the causes or to solve any of the challenges, many of which you've talked about tonight. So thank you very much, Michael. I will now close the meeting and thank the audience for attending.